Hi everyone, it's Dr. Kamari Valentine here. I'm a clinical psychologist registered in New Zealand, and I know it's been a while since I released a podcast. In fact, this might be my first for the year. There's been a huge amount happening, but what has happened most recently within the last week has prompted me to grab my microphone, even amongst the kids rushing around, and make this recording. I'm not really sure where to start in this, and perhaps I'll start with the acknowledgement that there is a huge mental crisis in New Zealand as well as in the world. We don't have enough qualified clinicians, and there are bottlenecks everywhere, but there are also issues that are not necessarily obvious when we look at the numbers. So, for example, when we look within district health boards, it is not as simple as not enough clinicians in a role, although that is an easy thing to say. So that's where I want to start, that there is a crisis. And I think there is a really important thing to be done to look at solutions outside of one-to-one care. Even though I've started there, that is not the focus of this podcast. On Tuesday, the Minister for Mental Health in New Zealand released a government notice about the introduction of what might be called Assistant or Associate Psychologist Scopes, and that the University of Canterbury in New Zealand would be the first to hold such a training program. This came as a surprise to me and many others, because we understood that the very issue of the scope was still under some discussion. In brief, the suggestion is that students who have completed a 3-year bachelor's degree in psychology would do a 1-year training and then would work seeing clients. This is in comparison to the requirements to be a registered psychologist or clinical psychologist. A registered psychologist requires a master's level degree and 1,500 hours of supervised practice. A clinical psychologist, such as myself, requires a master's or PhD alongside a 3-year intensive supervised postgraduate diploma, where there is intense theoretical understanding, but also very intensive supervised practice. In our final or internship year, we work typically 4 days a week in a range of settings. And back in my day, I worked for $1.99 an hour, which was an issue in itself, but I digress. There are a number of issues with the proposed scope, not least of which is that this term is misleading to the public, who may not know that associate psychologists don't have the qualifications of registered psychologists, and that what is being proposed is that these are practitioners who will be registered health professionals and who will be entitled to come under the Health Practitioners Competency Assurance Act. Thus, for any member of the public, there is no clear differentiation between this person and somebody who has further training. In this podcast, I want to talk about what the Scientist Practitioner Model is and why it is so important. the Scientist Practitioner Model will be absent for people who are training in the Associate Scope. As you heard just before, at the current time, in order to be a psychologist, registered or clinical, you have to have, alongside your clinical expertise and training, you have to have a research qualification. The Scientist Practitioner Framework originated at the Boulder Conference of 1949. This was where the idea came, or was formalized, I should say, to knit together science as well as practice in psychology training programs. The Boulder Conference was sponsored by the American Psychological Association, the APA, and the US Public Health Service. Attending this event were psychologists, educators, policymakers, and what was at stake was developing some sort of standardized training model for clinical psychologists. What they wanted to do was to ensure that practitioners were skilled in not only providing therapy to people, but also proficient in conducting research that would advance the field of psychology. It feels to me that at the moment we're at an age where people are skeptical of what research means, and I understand that is for good reason, so I hope you will bear with me. The Boulder model made it a requirement that at that stage doctoral level clinical psychologists were trained both in scientific research and the method of scientific inquiry and applied clinical practice. This dual focus means that we had professionals who could critically evaluate psychological treatments, contribute to research, and ensure that interventions were grounded in empirical evidence rather than some sort of snake oil. Clinical psychologists, then and now, are expected to be both researchers and practitioners, even if we are not currently doing active research as we might have done before, or as I did when I was a senior lecturer and postdoctoral researcher. The principles that I applied then apply daily in my practice. In practice, we balance our evidence base against clinical intuition. Clinical intuition, though, is something that we develop not only through our interactions with our courageous clients, but also because of the reading and training we do, because of the science that we learn. Our psychological interventions are grounded in scientific inquiry and based on evidence rather than some sort of anecdote or personal bias. What do we mean by effective treatment? Research-backed interventions mean that we study whether any one intervention brings about a change across many people. That means that this isn't just something isolated to one person, but that we can see an effect across a group. This increases the likelihood that we're actually reducing the symptoms that we're focused on and improving well-being. Now, what I want to chip in here as a therapist is that it is a two-way street. When we're looking at the data that comes to us from a group, we are looking at overall outcomes. By applying curiosity and reading the studies critically, we come to understand the limitations of any one study, but also the factors that were seen as important. We can then take educated guesses or make hypotheses about what variables might be useful for our clients, while also modifying aspects, given that each person is an individual. Each individual, though, is also a case, if you will, of n equals 1. This means for any person seeing us, we need to critically think about why this person is presenting in this way at this time. That is known as a formulation. And in order to derive our formulation, to come up with this, we're not just taking guesses. We're using the research that we know, for example, about disorders or difficulties, and using them to make a roadmap that is clear, that tells us about the interrelationships between factors that we can then focus on treating. So a scientific model matters because it ensures effective treatment. Secondly, it reduces harm. Without the lens of science, psychological treatments can be ineffective or even harmful, and we would not know. We thus look for treatments where there is this empirical validation of the findings and where the science has been done ethically. 3, continuous learning and adaptation. Being a scientist means being curious. It means constantly learning, constantly regenerating our hypotheses. Our field constantly evolves, and we need to keep staying informed. The Scientist Practitioner Model isn't just about one study or a series of studies or something we learned in our undergraduate degree, but it is about critical thinking and really reading with that scientific eye. Incidentally, this curious scientific frame of mind is also what we try to foster for our clients, so that our clients can be curious scientists of their own experience and the information they consume. One of my alarm bells about this new proposed scope is that these typically young practitioners are not going to have the same grounding in science. They are not going to have the grounding that doing your own piece of independent research fosters. So, for example, when I supervise intern clinical psychologists or teach clinical psychology students, that is, students who have already completed an undergraduate degree and who are either who have done research with me back when I supervised research, or who are practicing clinically, my expectation is that people will be able to independently go out and look, for example, at a particular, let's say, diagnosis, find evidence-based research that is not just about articles or what Google says or ChatGPT, and not only find this, but be able to critically integrate it. That means looking at the method sections. That means looking at the type of statistics that are done. That means looking at the results. That means looking at what sort of sample was used and what the conclusions are. This is a very high level of demand, and we do that because it isn't easy being a scientist, and it is not easy being a clinician, especially when we're dealing with so much that is at stake. We are working with courageous and vulnerable people. For clinicians, having this model of being a scientist practitioner means that we're constantly growing, we're deeply critically thinking, and we think about ethics in in quite a profound way, I would say. Clinicians who engage with research are more likely to apply effective techniques, but also to look at the data from their own client. Those of you who have had the experience of being taught cognitive behavior therapy by me back in the day, or perhaps other forms of supervision or teaching, will remember my saying that, what are you measuring and what can you put on a graph? This isn't to say that all data can be put on a graph or everything is measurable, because there is far more that happens than we can capture with our current science, but that rather we are responsible for looking at outcomes and measuring and putting into words or targeting our treatment. For clients, the Scientist Practitioner Model builds trust. Our clients deserve treatments backed by scientific evidence rather than personal opinions or trial or error or snake oil. I'd like to talk about cognitive behavior therapy, which is widely recognized and which I want to say is very misunderstood and very simplified. I say this because I had the good fortune to train extensively in cognitive behavior therapy, and then for my postdoctoral degree work on a randomized trial where the primary investigators were comparing CBT against, which was the gold standard, against schema therapy. When doing CBT in a way that is evaluated against the cognitive therapy adherence scale developed by Jeff Young, its name is different than what I'm saying, but I will continue nonetheless. Done in that way, I believe it to be different than people might be doing ad hoc, but doing it in that way and really measuring outcomes made me extremely aware of the importance of measurement, and also of the importance of having these trials where we are very carefully looking at why things work, or when things work, or who it might work for. My concern with the proposed scope is that in going for what is seen as a cheap and accessible solution, that we lose one of the real foundations that our profession is based on. And in doing so, not only do we do a disservice to our clients who are vulnerable, but also to the people coming in to be trained, because I'm afraid you don't know what you don't know, and I felt I knew far more at the end of 3 years of psychology than I do now. I'd like to end reading a statement paper by the Australian Clinical Psychology Association, the Australian Clinical Neuropsychology Association, and the Australian Educational and Developmental Psychology Association. This is a position paper. It is available on the internet. This follows the example of Australia trying to develop psychology assistance. And I quote, this is from page 4. There may be a perception that employing psychology assistance is cheaper and therefore more accessible. However, cheaper is a false economy. Employers end up with increased costs due to the extra support required, additional management and guidance, alongside the clinical supervision and training required for these staff. I said I was going to end there, but perhaps I will end with a parallel that I keep coming back to. If I hurt my leg and I was deeply in pain, or somebody I loved was in that predicament, I would want for them to not be seen by somebody who had a very basic level of qualification and then maybe 1 year special training in being able to talk to people. I would want for them to be able to see somebody who approached the matter with scientific inquiry, who not only had a hypothesis, but also a series of differential hypotheses and made a science-backed plan that was rooted in evidence. I have one of my children calling me, so I will end here. Please make a submission, please comment, please use your voice about the proposed scopes and help us keep people safe and keep psychology safe.